Wonderful. Thank you, all three of you. I think a nice example from all three of kind of the continuum of scale, thinking of regional, national, international levels, different health areas, different evidence base for different diseases. As I listened this morning and to the group breakout, one of the issues that came up often, I think, is relationships and communication and partnerships, and recognizing that I think it would be very difficult for any single entity to go to scale with a practice or program or set of practices and programs. And so I'm wondering for this first question if all three of you want to chime in and speak about what partnerships you have, how you've developed those over time, and you know, in terms of what recommendations might you have for facilitating this and moving this forward.
Well, you know, I'm a university professor. I'm not from a national organization, but so we started small in Texas and developed local partnerships with the larger school districts through that diffusion of innovation model I talked about, which means just going to school districts and finding the people who are interested and passionate in a topical area that we had solutions for, and then showing it to them and hoping that they picked it up. As we moved up the food chain of organizational hierarchy, we would go then to the State Department of Education, and we went and partnered with them and got our program aligned with the state educational objectives and then approved by the State Board of Education. That gave a great swath to say, you know, any school in Texas can implement this program because it's been approved. Then we went to the Department of Health and said, well, you have some responsibility for health education. Would you help fund us to do professional development? And they did for a number of years. So we developed partnerships in the Department of Health. And then the Department of Agriculture, too, which has a responsibility for the food, which is served at the school. So even though we're researchers inside of a university, we had to step out of the university and meet these elected officials and then find the sort of innovators throughout our state who are willing to accept the innovations that we had to offer, and we did. And then other districts looked at it, and then the snowball started rolling, and people from other parts of this country and other states started calling us. So that's how I got sort of not dragged into, but the evolution of this just became very interesting. How do you continue to do that? And I'll stop there.
Thanks. So for the work that we do, we primarily are helping governments on areas that are important to them. So the initial conversations about what matters to them and how we can get started. You can always make improvements on a small scale somewhere, you know, and that tends to work. But going to scale cannot be an external exercise. It has to be from within. And also the sustainability for what we're doing is not going to be maintained even if we could do it as outsiders. So the engagement from the very beginning that we'll come, we'll work with you, we'll develop the capability, we'll build the infrastructure with you, and that over time you are taking over and you're going to be in the lead when it goes to scale is key. So the type of partnership that's needed there is one where, designing the exit from day one, that's part of the arrangement. And of course, capacitating the host country government and the people who work with them is key to making this a success. And at some point, maybe I'll show a couple of slides that actually show how over many years something like this was done and was maintained.
So I'm going to so CMS is obviously a big payer. Gazillions of dollars go through CMS. But the truth is that we can't fix American healthcare ourselves. And that one example is that even if CMS said, hey, like tomorrow, we're going to start paying for, I don't know, your doctor to go to your house like every week to make sure that everything is, some sort of crazy pie-in-the-sky preventive community health thing, that's still only CMS. And so the core problem of what we deal with is that if only CMS decides to endorse a particular idea by paying for it, that still is not enough to move the market. we need to have the private payers join us in some way. And this is one of the core problems of what we're dealing with now. How is it that you get there? Patrick Conway, who's the chief of the Innovation Center, chief medical officer, he has this great line where he sits down with a bunch of chief medical officers of the private insurers, and they say, we love what you're doing, just keep going. We're right behind you, meaning that, that although we like to think the private market is doing a tremendous amount of innovation, there is sort of this lag that they wait for CMS. So there is this period of time where truly innovative centers, the ones we believe might be doing things that should continue, really are struggling to find sustainable funding in that meantime, because they're falling into that gap where the private payers are not catching up. And some of you who might be awardees of our Healthcare Innovation Awards are probably feeling that pain very acutely right now. Right? UTH, Nemours, others, great ideas, good stuff is happening, but that's one area we're struggling with. So let me know if you figure that out.
Great, thank you. That's a nice segue into kind of talking about and identifying maybe 2 to 3 of, I'm sure there are dozens and they change over time, but different barriers encountered when going to scale. Certainly financing and support for going to scale, management at scale, and sustainability, I'm sure is one that's common, but maybe not the top priority among all 3. So if you could speak to some of those barriers around going to scale, maintaining, and sustainability.
Yeah. Maybe I touched on some of those issues. Maybe I'll just put a twist on from the CMS standpoint, particularly from CMMI, which is we're in one of these situations where innovative approaches to community health are one of these things we're finding where the rich get richer. And what I mean by that is that it's communities that already have durable, highly invested institutions that are the ones who are applying for funding, that are recruiting sort of these individuals to come there to do this work. That leaves very large swaths of the country without these types of innovative solutions and focus on community health. But really, we're seeing that. It's almost like this divide between the haves and the have-nots, not in terms of what color you are, how much money you make, but the geography and the sophistication of the health systems where you're at. So I'd say one of the other core problems that we're very cognizant of is what can we offer to those communities? What can we do to allow them to participate in this very exciting time? And some of our ideas, that's why we have these 3 tracks. The low-touch track, high volume, maybe somebody in one of these places can at least take advantage of that, and that's something we're also thinking about quite a bit.
In terms of barriers, I would add a few things. One is with the recession which just happened, a number of things sort of fell off the map in school. So personnel that were responsible at school district level as well as at individual campuses found that they lost their jobs as state budget cuts happened across this country, many in double-digit categories in school systems that weren't that wealthy in the first place. So that got cut. Personal development days got cut. And even more distressing, there's a profession of school health specialists, and universities that support those programs are cutting those programs. So there's an upcoming and impending manpower issue, I think, of people who understand how to manage and implement and find effective programs. So that's a pretty macro problem. On the other hand, I see people in my profession who are designing and developing, evaluating programs, creating the evidence base, struggling mightily to monetize these programs or get them out into practice, because the intellectual property is maintained inside of the institution. And if you're like my institution, University of Texas Health Science Center, a little school health program has the profitability of an ant compared to a new cancer treatment drug, for example. So our systems aren't set up, our faculty they're not educated themselves about how to deal with intellectual property issues. So one of the things that we bumped into was we found an outside producer to print the catalogs and the materials and supplies and such and market it. And that was a good thing for us to be able to find a commercial partner. Although by finding a commercial partner ruled us ineligible for getting funding for the program that we develop, because many institutions don't want to fund for-profit agencies, which is one of the reasons I created the foundation. Now, So there's some interesting parts of the marketplace that one has to get some experience with, and that can be both a facilitator and a barrier if you're not quite ready for it.
Barriers are just so many. I don't even know where to start. But let me, as I was thinking, let me take a couple. One that we encounter so often, and it is a problem, and I don't know that we've figured out the solution to it, is that the change in staff and personnel at the leadership level and the facilities, and it drives us crazy because you've got this person who's a champion, they're a star, they're going to make it happen. The next thing you know is they've been transferred somewhere where this is all not going to happen, and it's a constant nuisance for us, but it is what it is. Now, the bigger issue, which I think is more problematic, is this notion that, now we've done it at the demonstration level, the pilot sites, we know how to do it. It's this notion that all we need to do is just replicate it over and over and over in a linear fashion. Now, that's the one where I think this is a huge obstacle. It's the notion that we have to repeat the same exercise over and over, not build on the exercise and amplify the exercise and use real spread methods that allow us to go to scale at a much faster rate than what we did and in a much cheaper way than what we had to invest in to get the initial demonstration to happen. That thinking is pervasive amongst leaders, and I find it really problematic. It's something that we have to deal with when we start, and no matter how much emphasis we put on it, I always find that there's this gravitational force that pulls them to, let's just repeat it. And that's probably the slowest way to go. I mean, it does, you do replicate, but it's the slowest way to go, replicating the initial demonstration. There are many others, and I'm sure they'll come up, but these are the ones I wanted to highlight.
Great, thank you. How do you evaluate your impact? And in particular, your population health outcomes, if you do. And if you do, how do you do that? As well as, do you, and if so, how, do you evaluate the actual spread strategy? So kind of two layers there.
Yeah, well, in our case, we've done a number of studies to determine efficacy. So we first do that before we roll it out into the field. And after that, we often get demonstration dollars. For example, we implemented Catch in all the middle schools in the city of Dallas. So I think there's 40-ish middle schools. And we were able to piggyback on existing fitness standard testing that they were doing, which allowed us to know the obesity rate and the fitness levels and such. So we were able to show that schools that were higher implementers had a stronger effect than those who were lower implementers, and in neighboring school districts too. So I'm always looking for ways to find use of public data when we go large. To go out and collect original data, that adds a quantum level of feasibility and dollars that usually are outside of control. In the school health world, at least, you can usually query someone at the school district level who will tell you, what programs or what methods are they using to meet state standards. And that could be done via a SurveyMonkey poll that are required. In the best case, you attach it to their funding level to fill this out. So at least you know a bit about what they're doing and how they're trying to be in compliance. And I guess lastly, I'll just add that and this is a labor-intensive way to go, but we recommend it as one of our best practices. In Texas and in many states, schools are required to fill out a campus improvement plan annually. So the campus improvement plans are often don't have anything in relation to health. It's all about something else. So we've actually gone out and written standards and put them up through our social media system and make them part of our training so that the school administration, the district administration, and then those plans sometimes roll up to the state agency level. People start seeing and knowing that you need to be in compliance.
If I can go to the standby slides, the second slide. So I'm going to show you a slide, but let me, in terms of how would we evaluate, first of all, what are we interested in improving? So if we can measure that same outcome um, at a much larger scale. And there was a notion, and I remember, I'll tell the story here, when we were about to embark on this work, on the scale-up of this work, the head of the health office in Moscow, where we did this work, said, if only we can get half as good results in the scale-up as we got in the pilot, we would be very happy. Which was a relief for me, because we're taking on something we didn't know. It was really a real adventure for us. We learned a lot from it. What surprised me was this. I'm going to maybe stand up to do this. Is that okay? We set out to improve, to reduce mortality from hyaline membrane disease in a place called Tver Oblast in the Russian Federation. And the demonstration, this is where we started, and that's infant, neonatal, and early neonatal. So this disease affects the first, basically if neonates are to die, they're going to die in the first week of life. This was the demonstration project. You can see the early neonatal mortality basically went down significantly in 5 facilities. We then went to a spread phase, which took it to another 37 hospitals, which cover the whole of Tver Oblast. And you can see, of course, the results were maintained throughout. So how do we evaluate it? Can we get the same result at scale? The interesting thing for me was this. We exited in 2002. I went for a visit, personal visit to Tver Oblast, and they invited me over. These are their results 6 years after we had exited from Tver Oblast, and they're twice as good as we left them. And that goes to the other question that Wynne asked about sustainability and the ability to do things, and that's one of my favorite graphs. Also, one of my colleagues pulled up a comparison here where showed, don't seem to be able to go further down. Yes, this is comparing infant and neonatal. They don't have early neonatal with the whole of the Russian Federation. As you can see, that oblast, which started worse off, was actually continued to improve far better than the rest of the country. Thanks.
From the CMS standpoint, a lot of the evaluation focuses either on reduction in total cost or in improvement in quality. And again, I've been talking about core problems. The core problem we deal with is correlation is not causation, right? Like how on earth do you know that the payment policy you put in place is responsible or not? And we can see that nationwide right now. Healthcare, Medicare growth rate is at historic lows right now. Is it because of the Affordable Care Act? It's hard to know, right? It's very hard to know. And I would say that, part of it is it depends on your political, your potential agenda and what you're trying to look at with the data. So if you are a community health advocate and you do a little study and costs go down, one assumes that it's because of the intervention. So, and unfortunately, the actuaries at OMB are not forgiving of that type of logic. So I think there's a long answer to your question. Part of it is that what is the design of the intervention? And these are lessons we are learning and continue to learn and have learned very painfully. That if the interventions and the experiments are not designed in a way that actually answers the question, it is highly unlikely that no matter how you massage the data, you try to risk adjust or find some comparison group, that data is going to be very unpersuasive. And this is one of the things, I've been thinking about pediatric asthma and why it's been so hard to get private payers to buy in. And one of the thoughts is that the design of many of the interventions has really been truly agenda-driven in the sense that people think this is a good idea. And when you really look at the design of this and the way that the cost savings are calculated, if you're a payer, they don't withstand scrutiny. I'm not saying that broadly, but I'm saying many of the interventions that are out there. And so this is a long answer to the question that evaluability, what we are starting to think is that if we are going to get durable results in some way, the gold standard should be that we randomize the interventions we do. And that's very difficult to do. It's something a lot of people talk about. The government's been criticized for not doing enough randomized studies. But this is some of the pressure we're undergoing, and actually rightly so. So I would say that up front then, if we do the cardiovascular risk reduction model that we're exploring, that will be a randomized study. So that will ideally give us that data. So some individuals would get the intervention, others would not. In terms of the AHC pilot we talked about, that's not randomized, but at least is a dose study. So at least the internal controls are theoretically built in some way, and we could get helpful data along those lines. So I'll stop there, but I'll say that having sat in all these evaluation meetings, they invariably deteriorate into people get mad about risk adjustment, and I've just started to think that's sort of a fool's errand at this point.
Can I go back just
Yeah.
a sec? Two other criteria that I forgot to mention. The first one is not only did you get the result, how long did it take, which is another factor. And the other thing is the cost. In this particular case, the cost of the scale-up was essentially the same cost as the initial demonstration, which is sort of how good was the result, how long did it take, and how much did it cost?
Great, thank you. One last question before I open it up to the audience here. And just as a side note, lunch is now at 12:30, I'm sorry, instead of 12:15. But that means we have a full half an hour, if not a little bit more, for questions from the audience if folks want to start lining up in a minute or two. So interested in recommendations from all three of you for similar others, individuals in university settings, in organizations and federal agencies, for other people who are thinking of doing this, such as those in the room and those watching, and hopefully more and more individuals and organizations in the future. Maybe one or two kind of relatively brief recommendations moving forward.
Just go with a couple of them. I think I mentioned a couple of them first previously, and that is, if you're going to do work in schools in a state, go and talk to your state agencies, and especially go talk to your state board of education. I believe most states have that. Find out what's going on with them. Find out if your program elements will work. Second, I think using the snowball sampling sort of strategy of finding the innovators and the early adopters really does matter. So I think educating yourself a bit on diffusion of innovation. There's other models that are analogous to it, but it's the one that I happen to know. And then in my case, it's just linking your priorities with both federal and private philanthropy interests too. So if you find a way to coincide your interests and have missions which are interlocking. You know, I mentioned MD Anderson. They're not a traditional place that would do population health, you know. So I'm in deep discussions with them now about, you know, reducing the smoking rate in the state. What would they want to do? So we're finding objectives of what I want to do in population health with what they're interested to do with the resources they have. So I'm a population health expert, and so it works in schools. So they're interested in increasing the rate of HPV vaccination. You know, they would love to say it's 100% in Texas. You know, when could that happen? So my group is now working on that problem. So we're trading resources and intellectual property, if you will, that way. And because of that, I think we'll be able to continue on.
Three key things I would probably emphasize. The first one is starting with the end in mind, because I think if we know what we want to achieve where we want to be at the end, then designing how we get there becomes much more deliberate, and we're probably more likely to be successful at getting there. The second is I wouldn't start everywhere unless I was really sure of what I was doing. And if we're starting with something small, then be deliberate about the choice of that in such a way that gets us there, and the people whom are going to work with us at the demonstration level, because they're probably the best people to take it to scale, and having an upfront agreement with their leadership on that will work with you here, but the people that really excel and find themselves in this, we want you to release them to be able to take it to the full scale. And if we're dealing with, you know, somebody who's in charge of a large geographic area, then the likelihood is he will release his staff to get that good result everywhere in his system. And the third one is a very deliberate transition scheme, so that yes, you start with more assistance, but you really want to be exiting to the extent possible over time, and handing over leadership, and at the end stages, you want to be in the background rather than in the forefront doing this.
I would agree with all the things that are said. I think the only thing I would add is if you're working at a large health system, or I would try to engage the private payer partners at a very early stage to make sure that they have some input and feel they are participating in part of the design of your intervention. The second thing I would say is to, a priori, and if you can afford it, an independent and very well thought out evaluation strategy prior to the intervention.
One last point that I forgot. Working with professional associations, for us, when we decided to start working outside of Texas, we would go to the American School Health Association and present there, the American Superintendents Association, the American Elementary, and and so on. And we were purposeful on trying to present and spread the ideas and the data that we had collected on the efficacy of these programs. And then it made it a bit easier to start engaging in professional development, first starting through professional organizations, then working with their local affiliates.
Great, thank you all very much. Questions, comments, thoughts?
Yes, okay, where we go. Okay, thank you. Thanks to the panel. Dave Kindig, University of Wisconsin. This is a question for Darshak at CMS. And by the way, it's great to have someone with your perspective in that role. Thank you for becoming a federal bureaucrat to do this work. You hinted, this is about your ACO dose strategy. So two questions about that. One is, could you give us some hints about how you might incentivize the higher doses that you envision? And then second, I thought you implied when you talked about the divide between more sophisticated early adopters and the rest, and the gap in the rest of the world, I think you implied that it would be the lower dose that would be most for the less sophisticated places. And I'm wondering, did you mean that, and if so, why?
Sure, well, I'll take the second part of the question first. No, I didn't mean to imply the lower dose was more effective in those areas. I just meant that the higher dose, in other words, we're talking about, integration of community-based services financially, potentially in some way with large health systems, a rigorous network of potential community health workers that can help do this, as well as, in addition to that, doing continuously updating the community-based resources. It's just a heavy lift. So I just meant that it potentially just the barrier to entry, you could say, hey, I'm a small I'm a small health clinic in a rural area. I don't have all that. Can I at least get into the game in some way? So, but if one is interested in pursuing the other track, you would be more than welcome to do so. Yeah, it's a good idea. Yeah, well, let's explore that. Yeah, as we say. Yeah. And the other question you asked, I believe, is to say, well, if incentives are so important, can we enhance the incentives in some way, particularly around potentially ACOs? And most of you are familiar with ACOs, but you have there's a couple ways one can do that. And it's not just incentives. So just to air this out, ACOs are complicated. You can talk about attribution. You can talk about how you come up with the targets, and you can come up with what is the actual percentage of cost sharing. And each of those things may have some substantial degree of bearing on how an ACO may choose to focus on a population and what those incentives may be. So one way to look at it could just be that, why are we being so ginger about going to full risk for an ACO? Say, look, just capitate the payments in some way, create a full risk ACO, and that'll be enough. I would just submit that may be a reasonable thing to do, and actually we are exploring models like that now through the ACO group. But the other thing is, what is the attribution? Can you contact those patients? Your network is only as good as the communication you have with them. What good is an ACO? People don't even know they're in an ACO, or for that matter, what an ACO even is. Should we be thinking about that in some way? And then finally, I'd say, what should we allow patient choice? And then if not, how should we attribute? Should we do it prospectively or retrospectively? I would just say these are deep questions, and there is a lot of thought being given to this. offline, if any of you are interested in this, please let me know. I'd be happy to connect you with the folks that are working on this so that you can give input directly to them.
Buenas tardes. Rashad spoke about the difference between amplifying and sort of like reproducing a program, an intervention. And not to pick on Rashad, but you mentioned the 3 tracks as an example. And I really thought the 3rd track was gonna say, you just house the homeless veteran, right? So there's a 4th track, which is that edge between where your responsibilities as CMMS and somebody else's responsibility starts. So I would like for the 3 of you to speak about this problem of edges between systems, and if you're more biologically inclined membranes, like that space where things like start to separate. Thank you.
I'm happy to start. Any other thoughts? I'll just be very brief. I think what you're talking about is the issue. I think when we talk about these membranes, remember, they're also there for a reason, right? People feel that if they own a certain problem, that they're more invested in dealing with it. So I would just say that when we start to remove those barriers, that it'll be very complicated. But one could do that, right? You say, look, why are we paying for this person to keep going to the ER? Why don't we just why don't we just install an elevator in the building and put air conditioners in everybody? You know, something along those lines. Or as you said, yes, this person is chronically homeless. Why don't we just pay for housing for them? Isn't that smarter? And that could be. The other side of that is, well, you know, the minute you start giving away free air conditioners, like, I kind of want an air conditioner too. Like, if you're giving away free housing, I'll be signing up for that too. So there's this issue of leakage, and how do we control that to some extent? I'll just say that this is exactly the problem we ran into with post-acute care, right? We thought this is a great idea. Look, we're going to have post-acute care. We're going to get people out of the hospital. And post-acute care is now the biggest driver of variation in Medicare spending nationally. So there's just complexity around that. But a path forward might be one that, say, Hennepin Health in Minnesota has. And people talk a lot about it, but when you get at the core, what is it that they're actually doing? What they've developed is essentially a per member per month, because it's a prospectively paid Medicaid MCO, but they also have that type of agreement with their other social service agencies, corrections, housing, welfare. So they have unique identifiers. So while the money is not physically in the same bank account, they actually, somebody there at the county level has that view. We are spending a lot of money on this number of patients across the spectrum. Why don't we think about that? And so that's why then they recently invested in a center for chronic inebriates or alcoholics, because they felt that across that spectrum, that's where a lot of the issues were. And then ultimately then they would see if those costs were reduced over time. So I think, very long answer to your question, but I think perhaps one way forward is virtual braided funding. And maybe that would be a component of one of the models that we're exploring. But I'm, again, very open to feedback. So offline, if you have ideas about what you think we should be doing, I'd love to hear them.
So from another world, you know, I totally agree. I don't think we should be creating these separations. I think we're going to serve a better purpose by putting them together. The place where that comes so close to us in our work is the area where that becomes very apparent to us is in the area of caring for orphans and vulnerable children, which sort of started with the AIDS epidemic and now has become, in the last few years, a key part of our work. We're not talking about healthcare. Healthcare is part of it, but it's only part of the bigger picture, and we're having to look at other aspects such as schooling, such as food, such as other things. In fact, with AIDS today, a lot of nutrition work is coming in a much bigger way than it used to be in the past. So I think if we start to break down these barriers and we start to look at the bigger picture, the likelihood of us achieving better health outcomes is even higher, because they're all interrelated. Thank you for that question. It's a great one.
My world's a little bit different than you guys, but I guess it's not that different. And, you know, Texas, if we just look at that particular state, there's a great deal of wealth distribution. It's inequitable. I approach that problem in thinking, you know, if I'm doing work in the Texas border communities versus, you know, Dallas, for example, where there's Neiman Marcus headquarters, Those are very different approaches. So it often turns down into resources to a certain extent. You know, if I had my way, I would, the best randomized controlled trials say if you bring outside staff and put them as part of the school and you control them centrally rather than adding an additional burden to an existing staff member who's professionally trained in another dimension, that you'll get better outcomes. But that's an extremely expensive proposition. So I guess the short answer is we try and customize and tailor our approaches to the local communities as best we can, using their own value and belief systems as well as their prioritization of problems, which is why, you know, in my career I've tried to develop expertise in smoking and alcohol and injury and violence and tobacco and physical activity and HIV, STD, pregnancy prevention. So I have a portfolio of projects that I didn't create all of them, but our team may have, or other institutions, and can make recommendations to schools based on the problem that they're interested in, not just the ones that I have funding for. But I did get a little frustrated with that approach, and because of the lack of resources issue. So we either work at the state level, and I bang my head against the Texas legislator every time they go in session in next month, to try and allocate resources. So you can do it that way. But I guess the bottom line to your answer is professionals that are interested in moving the needle in population health have to figure out ways to raise money, too. You just have to. The money's not just hanging out there.
Great question, great responses. Folks, if you would just remember to state your name and your affiliation, because we are recording this for purposes of summarizing the workshop today, that would be great.
Neil Kaufman, UCLA.
His name's Neil.
My name is Neil. Last name Kaufman, UCLA. My question really relates to the partnerships that can be created between private sector and universities. And really looking at what are the barriers, more importantly, what are the solutions in trying to take things that have been proven to have evidence base. For example, self-management support we know works. There's programs for obesity that have been created by the CDC and the NIH and academic. And how do you build the organizations? And I'm involved with one. We feel like we've been successful at it, but the question becomes, what are the fundamental ways to, you were saying, intellectual property rights. Well, there are ways to do that. There are ways to bring money back to the university, to incentivize the faculty, to incentivize business. Our methods with SBIRs, STTRs are ponderous and take forever to get compared to Canada, where you can get better funding. So I just wonder what suggestions you all would have to help that partnership be much more robust.
Well, specifically in my instance, I think one needs to go and learn the rules about intellectual property, which means go and visit the technical, what do you call them, the IP office, and figure out how to do it. The foundation, as I mentioned, I just created, really it's a thorn in some of the university's side. They now see me as competition, like I'm working in competition with programs that I've created, even though when I raise money for the foundation, royalties go back to the institution. So, but it's only 4 months old, so I figure, you know, things will settle down eventually. And having, being a full professor, an endowed professor, helps in that regard too, because it is a little bit nerve-wracking if you're an associate or have not tenured yourself. So my advice to people within academia is to know those people well. And if you're looking for a partnership on the outside, either as a public institution, the licensing agreements can be, at least in my case, can be modified based on the royalties paid to the institution in a nonprofit setting versus a public for-profit institution. So sort of learn the rules about that too. And I can come back a year from now and tell you whether I can pull off building this organization, because we just started.
Thank you. Go ahead.
Mary Pittman from the Public Health Institute, and I wanted to pose a question to Dr. Massoud based on the 4 models that you had for scaling: collaborative improvement, extension agents, wave sequence spread, and hybrid models. And I wondered, how intentional are you when you start out to choose one of the scale models, and to what extent do you actually teach the people that are working with you about the theory, about those models, and so that they're also intentional in what they do? And then when do you just let it kind of merge together?
Great question. First of all, I'd say 3 of them are models. The fourth one is really a mix of anything. and every one of them, and everyone in the fourth category looks very different from the other. How intentional are we? I mean, part of our onboarding for our staff includes how to go to scale. Even though we have that as part of our onboarding, I don't know that I'm very happy with the level at which it happens. We still continue to work with our staff in the different countries, and we do have a requirement, which is to have an actual plan for each of the activities. So that's when we see that, you know, this is going this way or that way. Unless we see something that doesn't look technically like the best approach, we generally will, you know, the different countries will make their own decisions, and that we give a lot of leeway for. But we do provide provide them with assistance, and a lot of them will seek the assistance, and they do that all the time. So will one of them choose one approach versus the other? We've had that, where some people say, I'm comfortable with this, I think this will work, and you know, we let that happen, and others will be more deliberate about saying, well, what do you think we should do? And if they ask the question, then we will help, you know, engage more with them. I wish I had a straightforward answer. It isn't, and you know, when you run an activity of this size, you have to give a lot of autonomy to the different pieces. Otherwise, it becomes a we become a bottleneck for their work.
I'm Sally Herndon.
It's not on.
Sally Herndon, North Carolina Division of Public Health. I like the term that you used, virtual braided funding, and I have an example that's about to come true in North Carolina, I think in January, where we've built support for affordable housing and public housing going smoke-free with the private sector. And there was a public hearing where there was support from bankers and housing professionals to provide incentives for affordable housing opening smoke-free. There are two areas where I think we're ready for spread and reach that relate to health and housing. One is healthy homes assessment for kids with, especially for kids with asthma. It's evidence-based, but we don't have funding to do that. We find in North Carolina that there's a reduction in ED visits with kids with asthma if it's non-controllable and you go in the home and you assess the asthma triggers in home and help ameliorate that. It's not rocket science, but it takes the right kind of person to do it. The other area is in the area that's most dear to my day-to-day work, which is just fully paying for quitline services. CMS offers federal financial participation, but it really doesn't pay for the full services, and Medicaid users are some of the highest. About 60% of our quitline calls come in from Medicaid. So it would be helpful to us if we could just get that full help to pay for those quitline services, because Medicaid is a big user. Thanks.
Thank you very much for sharing that. Again, I'd love to continue that conversation.
Let's talk
as
some
well.
more. Thank you.
So George Isham, Health Partners and co-chair of the Roundtable. So stepping back from each of your discussions, I'm struck by how each of you have very situationally dependent sort of views of spread, scale, and impact. And it's really one of the wonderful things about the design of this panel. And so, and I've also heard, Stephen, you talk about Everett Rogers, and Darshak, you talk about controlled trials. And I guess that is somewhat, and I may be wrong, but it may be a little bit dependent upon where you sit and your issue and where you come from in terms of professionally and your task. In terms of Rashad's comments, I'm not quite sure, you know, what sort of evidence base you look at for spread and scale and so forth, but you're clearly working at a scope and a breadth that's beyond, what your other colleagues are looking at. So my question is, in terms of what you are listening to so far, do you think that the evidence base for spread, scale, and impact that you are looking at is complete? Or is it siloed? Or is it, can you learn from some of the other examples, just in what you've heard so far today? Because it strikes me, in just listening to you, that some of the things you're talking about and so forth may not be consistent with an overview of what we might look at in terms of spread and scale if you thought about it in these different settings. And if you looked at the different literature sources, like the business literature, the gray literature, the biomedical literature, and so on and so forth. But so this is a little bit of a speculative question. I'm interested in your take on the evidence base for scale and spread and impact, given your work and given where you think you sort of fit.
I could say that question is multi-layered. So I think maybe the way I consider it is that if the ultimate goal of this is to have healthier individuals living in healthier communities, spread, scale, and impact is a multi-layered issue. We at CMS can look at one or two parts of that, which is the payment incentives. But I tell you, you can pay me like $10 million and I still won't be able to replace your knee. Like, I just don't know how to do that. So I think that part of it is not only to get the payment incentives right, but to create a rigorous system of professionalism and education and community engagement. And that has to come, we can light the match for that, but there's a whole other science that I would depend on to my colleagues here and in the room to determine how to do that, which is that getting the financing, while it seems very important, is really just the first step. And we haven't figured all that out yet.
Well, the straight answer is the evidence-based complete? No, it's not. And it's not complete, and we're far from it, and I don't know that it ever will be. So even when we get to a much higher level of sort of knowledge and grounding in this area, there's still going to be more to develop. But let me go back, because I think we're sort of answering some questions and we're not putting things in totality. So for example, when I first started to do this work, I relied heavily on the learning from Everett Rogers as well. And in fact, when I do a sort of a larger presentation on this, I talk about what have we learned, what we think remains constant from what we've learned from Everett Rogers, and what we think has changed. So some of the graph that you showed, for example, I will give personal examples of how the same person over time changes with respect to the same innovation, and the same person will lie in different places depending on what innovation we're talking about. So that same base is the base that we use. The work that I described, and this is actually one of the first pieces of work that we did in this area. When I joined IHI, I took this and I worked to further evolved it in health systems in the US. So for example, we've used this same approach, wave sequence, at Kaiser Permanente. They've evolved it. They've really taken it to a very different place. So we've used those domestically as well. They've also been applied in other countries. We've applied them heavily in African and Latin American and Asian contexts. So there's been a sort of an evolution throughout, and some of it has come from what exists. Some of it is experiential. Some of the things I hope I'll get a chance to share with you is what we've learned about the rate of spread. So when we go to scale, do we need as much time? You can see here, we gave ourselves 2 years and we were able to spread, but I can show you the rate of adoption, which is an incredible phenomenon that only came about by doing this over and over and seeing the same pattern, recognizing that there is something there we should learn about.
I don't have a whole lot more to add to that, but of course the evidence is not complete, as you said. In my world, I deal with young children all the way through age 14, and there's some things that we know work with middle school kids that aren't going to work with preschool and so on. The problems are different, the solutions are different, the personnel are different. So there's always new ways to make it better and run smoother and to get outside the silos. I myself have looked at literature. I mean, I have to know how to talk the medical literature to a certain extent because there are pediatricians and family practice docs and OBGYNs and nurses at schools and things like that. And I need to speak to the economists too to understand, cost effectiveness studies and qualities and things of that nature. Because if I can present that information, it makes it a little bit easier at the state level. I need to understand state government. So there is a lot to know, I think, to deal with population health. Either you learn it yourself or you form a team of people who have that sort of area of expertise that can work on it all simultaneously.
Sandy Magnan from ICSI. So I wonder if you can give some advice to our roundtable. So the roundtable for population health improvement we've talked about 3 goals. 1, increasing life expectancy and other health outcomes. 2nd, decreasing disparities in those outcomes. And 3rd, decreasing health care expenditures, capturing some of that and being able to put it back into improving those outcomes, getting upstream. So how do we do that? Steve, you said we could, health professionals needed to be good at raising money, or do we need to be good at figuring out how to decrease healthcare expenditures or decrease rising costs, capture some of that, and put it back in upstream into many of the things you're talking about? So what if those are our goals, increasing life expectancy and outcomes, decreasing disparities, and decreasing healthcare costs so we can put it back in upstream? That's what we've talked about as a roundtable. What advice would you have to us? What do you think we should be focusing on first?
Well, you could work in children's health and do all 3. That's selfish of me to say. We have a number of 1115 waiver projects in Texas because it is Texas. And a lot of people in my field are talking about the 3rd objective that you're talking about. So can you demonstrate population impact so that then can you figure out how to take the dollars which have been averted and use that to prime the pump to continue doing the work that, so some of us are trying to use the 1115 waiver dollars to demonstrate that you can achieve the population impact. So and then if you have the right economists or other healthcare professionals really looking at the costs and determining what those savings are, then you have a persuasive argument, I think. And there's some places where that's happened in large-scale tobacco prevention control. I know in Texas, when the settlement dollars came to Texas, there's a group of people that worked in East Texas and did a really nice job of reducing population smoking prevalence at adult levels and also preventing the onset. And so they did a full community from kids to older folks, and they were able to quantify that. So there's a position paper that says if you spend this much, you get this much back, and that this much back is in excess of what you spent. The trick then is, I don't know, you might know more than me, but how do you get the systems to say, well, you're saving dollars in one system and trying to put them in another system? That's a bigger challenge than I know how to fix, and I'll have to rely on others. Life expectancy, to me, that and the health disparities, I think one has to prioritize. The example I gave earlier, HPV, so much of cervical cancer is related or caused by HPV. If I could just get the HPV rates higher in Texas, you could down the road actually see what you're talking about in the healthcare expenditures. So that's an infrequent disease compared to obesity or cardiovascular disease or all forms of cancer, but prioritizing and figuring out in a stepwise fashion. The other advice is, that this work, just like it's happened in my career, at least in all of ours, it just takes time, right? So the quick and immediate solution on these 3 dimensions will probably go on longer than the length of the panel.
A few quick thoughts. The first one is the UN summit on NCDs a couple of years ago identified best buy interventions. These are primarily preventive interventions that will give us the most impact, the lowest cost. So that would be a great place to start. The second thing is targeting the people affected most probably would address a lot of the disparities issues. And then breaking down the barriers, the question that came up from our colleague earlier, because if we deal with it as health sector only, the likelihood is we won't make as much progress.
Just have a thought on that. So the first, everything old is new again, right? So essentially what we're talking about is what is the mean and standard deviation of lifespan. We call that sort of, maybe that's public health, and we call the latter now population health or disparity. So how do we make that tighter? I would just submit that, I'm just going to put it out there, most people don't that just doesn't mean anything to them. Like, I have to say, most people don't care what the average lifespan of America, they really care about what's my lifespan, do I feel better? So I'd say the first challenge is how do we sort of disaggregate that from the language that we think in into language that is sensible to the average person. It's one of the things we talk about sustainability is getting community buy-in. And I think that's going to be one of the first things. Whether it's going to be smoking, whether it's the health of our children, I would disaggregate that into what the core issues are. And the other piece of it is as we do that, the one concern I have, and I say this as somebody who works in Medicare now, is that we focus so much on cost effectiveness. Quality adjusted life years and so forth. I personally, I just don't, I'm really speaking like sort of from my own opinion now. I find that those numbers are just totally bogus. Like they can, maybe I shouldn't say it that way, it's going to get reported publicly, but I think it's like, but I think that they are so strongly subject to bias. And you could just look at how, when you look at HIV medications, it is not worth it to do it in Haiti, And then Paul Farmer and it comes along and negotiates all the prices, makes more. Suddenly now it's cost effective. So one thing I would do is to, I'll say this out loud, even as somebody says, without regard to cost, what are the things that we should be doing to get to those goals? And then, we also talk about scalability, and Jeff Brenner says this. I say, I'm a pediatric cardiologist. Like, I have to say, doing like heart surgery on a 1.5 kilogram infant to repair hypoplastic left heart syndrome, that doesn't sound very scalable, but we did it. Why is it so complicated to scale this other stuff that's arguably less complicated than that? So that's sort of what I would say is that one of the things we depend on for the broader community is to take things that seem hard and show us how it doesn't have to be so hard. And then we'll find ways to pay for it. So that's the second thought I have.
Just a quick update, food is en route, but we are going to finish these three individuals who have questions, and then while we are waiting for them to get here, transition to the next panel so we don't get too off track for today.
I'm Pamela Russa from the Robert Wood Johnson Foundation, and my question was very much aligned with Sandy's, and it's mostly to you, Darbeck, which, although I don't have a good Medicare example, but so we had a previous workshop on sort of resources, right? And sort of more innovative types of resources. And one of them was social impact bonds. So, the example that we had was if you did something on home visiting in South Carolina, wasn't it? That you could, the prediction was, because they had to do a whole feasibility study, the prediction was that you would save Medicaid in that case a tremendous amount of money while improving outcomes. But the question that I never really heard answered was, so then I suppose it's Medicaid that pays back whoever invested, but would Medicaid continue to make that investment? Or would they say, great, you demonstrated it, but that's it?
So I think what you're asking is, are you asking, does a social impact bond make sense as a bridge form of funding to
how does
sort of?
that work in the
Yeah.
Medicaid, Medicare?
So I'll say a couple things. The first thing I'll say is that we are exploring the use of, at the federal level, they call this pay for success.
Yeah.
People like that term socialism, bond, like that doesn't go over as well, I guess, politically. But so we like to say pay for success. So I'm learning all this recently. Yeah, but I'm being facetious. But in seriousness, I think that there are two issues to the argument. The first is, suppose, all of you hopefully have retirement funds, right? Suppose I came to you and said, I've got this great investment for you. It's a total winner. Put all your money in. There's a chance you could lose it all. Pretty high chance. And if it works, it's awesome, the return is going to be about 10%. How many of you would invest in that? Like this, I think one of the core issues we need to start with is accept the fact that social impact bonds are not going to be an extremely attractive investment vehicle because they have to be, I mean, people always talk about Goldman Sachs invested in the New York prison recidivism experiment. Goldman Sachs has not started a very large social impact bond practice in the wake of that. And I can tell you that they like money and would pursue this if this was a fantastic investment opportunity. So I think the first thing to accept is that this is really going to be more of a charitable adventure. And if we accept that, then the question is, if it's going to be charitable, then is there really a strong financial case that's going to emerge from that at some point? And I would submit that if these are such great ideas that maybe people are going to invest in, social impact bonds may be helpful as bridge funding, but ultimately what's going to happen is there has to be a rigorous political process in the background. You're buying time, essentially. This is at least my view, at least because this is not widespread, until that political process in your state, in your community, or with your insurer can then take you to where you want to be.
Part of the decision is on this notion, for example, we've heard, that Medicaid in some places is supporting housing as, as an appropriate investment. Is that a state-by-state decision or a federal decision?
It's a good question. I should say I don't know enough about the particular waivers to answer that with a high degree of fidelity.
If I could just piggyback on what you just said and what you asked earlier about intellectual property. And, a lot of work is charitable. You're right. In my field, it's charitable mainly because state budgets have been cut so much, and that fell on public education in so many places, and the work in health education and training the next generation of kids to know how to be healthy is evaporating rapidly, or has. The reason why the private marketplace hasn't stepped in with the intellectual property is because there's such a thin profit margin compared to, drug treatment or many other treatments. So I'm not real optimistic that the solutions that get built in carefully done studies are actually going to be profitable if you try and hand them off to other agencies. And some of them can be, I guess, if the company, the private entity that you're working with has a large enough scale system, potentially could, a textbook publisher or such. But many times our interventions are bigger than textbooks. It's not just a textbook. So, that's the challenge, and that's where, finding those charitable contributions or taking the long route and asking the state agencies to do the right thing, if this is the right thing in the whole state's opinion, then maybe that can happen. So I think you have to hammer away at both of them.
I want to weave a few things that you've been saying. The lifespan issue, I actually don't care about my lifespan, I care about my performance span. I want health, as Lester Breslow used to call it, the resource for living, so that every day I can do the things I want to do. And I think the more that we focus on performance span, the better off we would be, and particularly as we're aging. And so that gets back to your idea that says we're going to look at the risk of cardiovascular disease 10 years from now. Why don't we look at the risk of accumulating your second or third chronic condition? That happens every couple, 3 years. Individuals may still stay moderate risk, not very expensive, but they progress and have more cost, which we've been able to demonstrate if you help them lose weight or help them self-manage their condition in a cost-efficient way, you can actually save money in the short term, meaning a year or two. Is that the kind of approach we should be taking to be able to demonstrate a fairly rapid ROI, a fairly rapid value on investment, which will then obviously change your 10-year stroke? It's a very different approach than taking care of the hospital readmission rates and the very, very sick.
Could you state your name and affiliation for the record, please?
Neil Kaufman, UCLA.
Thank you.
I think that certainly makes sense in a diabetes conversion sort of perspective. I mean, it's right there in front of you that makes sense. Or skin cancer, sort of screening. Public health being considered as screening of adults makes sense, absolutely. And you can see those dollars.
Even something more mundane like sleep apnea. If you can lower the rate of adding sleep apnea to overweight and obese people, they don't get hospitalized, but they don't have to have a CPAP machine, and that saves a lot of money, keeping you from getting high cholesterol when you didn't have it, high blood pressure, arthritis, low back pain, everyday common things that accumulate as you age when you have those additional risk factors. So it's not just the prevention of diabetes, it's diabetes and complications also.
Well, absolutely, yeah. You know, with severely overweight, with the severe obesity overweight problem in America stemming down now into kids in middle school, and the advent of bariatric or other sorts of surgical techniques to take care of that, I mean, you can start doing those sorts of cost analyses. And in my field, we say it's better to prevent the morbidly obese kid or severely obese kid by the time they're 17. I would say in Texas, the latest number was 13% of African-American high school juniors are severely obese with a BMI in excess of 40. So what do you do about that? I mean, do you provide the treatment for 1 million kids? Or do you prevent it in the front end? So you could calculate those costs. It's conceivable.
Yeah, I would just say that all those things make a lot of sense. And from our perspective, we're just going to try to walk before we can run. And so if we can at least demonstrate it, that this makes sense in this one context, hopefully then we can expand it to potentially the types of things you're talking about.
Last but not least.
I'm Jeanette Noltenius with the National Latino Tobacco Control Network, and it's been a fascinating discussion, and there's an element that has been concerning to me. It was wonderful to hear that eliminating disparities is an issue, and that's what we're trying to do. But the other issue is, what are we measuring, and are we really going deep enough to see the disparity and the diversity within the disparity? That concerns me in two ways. Are we going to get the money to be able to measure and to have the right data? And secondly, what is going to be the impact and the cost of having large, poor populations with multiple chronic diseases? I don't think we are looking at this in a projection way in terms of the changes in the census and the changes of what America looks like in terms of color, in terms of class, and in terms of disparities there of income.
I think we need more research to, well, I hate to say more research, because these problems are right and they've been in our face for a long time. Research in the sense of demonstrating efficacy within certain groups to try and then project out into the future to understand it then, and that becomes a manpower issue for the hospitals, but it also becomes a prevention issue about screening and about trying to reach the populations who are at a health disparate risk. So, you know, in our group, we work down in Brownsville, Texas. Maybe you know Amelie Ramirez and some of the other folks that are working in the Latino community in Texas, and some of our best results are out in El Paso, and in Brownsville, and in San Antonio, and in the African-American community in Dallas. So if the evidence base is there, it's a lot easier to do the things that need to be done, I think, and to build the argument that says to the state legislature of Texas, we need to do this. You know, we can do this, we've done it, now we just need to fund it. So I don't want to, there's a few private things I'm trying to do at the state legislature right now that might actually help in that arena.
I would just add to that by saying that, so, and this gets back to something I was saying, is that do we want to further subcategorize the issue and say in these communities these problems are more prevalent? And that may be helpful, and it may be an important question from the standpoint of social justice. I would say from the standpoint of large health systems and public health agencies, I would encourage us to think about the opposite approach. And the example I think we could point to is the VA. In the 1990s, when HEDIS measures were collected and publicly reported, without any obvious payment incentives, and you're just looking at, say, LDL cholesterol screening of patients who have diabetes, something people should be doing, there are major disparities, right? African-American men who were veterans, about half of them were not getting screening. So you could say, and that was much worse than the rate of at the time, were categorized as whites. But if you look at the whites, they were only 70%, were 55 or 60% were getting screened. So yes, there was a disparity, but the bigger problem is that nobody was getting great care. And so the solution was it's very simple, which was transparency and public reporting. And simply with that, by the end of the 1990s, all veterans were brought up to a rate of about 85 to 90%, and the racial disparities were no longer present. And so one way that I think CMS has approached this, and I can't speak for CMS broadly, but I would just encourage us to think about this, which is what can we do that actually improves care for the entire population? Sort of the rising tide lifts all boats, rather than always saying, well, for this particular community, what should we do that's special for them? And that doesn't mean to say there are not culturally appropriate things we should be doing, but I would argue that potentially at the stage we're at now, the biggest yield could come from the public reporting, measurement, and transparency. But obviously there could be a lot of debate on this discussion.
Thank you.
Great, thank you. Thank you all for the great questions, and thank you to the panelists for their responses and discussion.